So we know that checkpoint inhibitors are approved now for metastatic disease in patients who did not respond to platinum-based chemotherapy. And they're also approved in patients who are not eligible to platinum-based chemotherapy. The problem is that they don't have a complete response. Even the best case scenario is about a 20 to 25% response. And so people are looking at combination therapies. They're not only looking at combination immune therapy, but also looking at combining them with chemotherapy, at least earlier in the earlier setting. So there are several trials right now looking at neoadjuvant therapies, combining chemotherapy with checkpoint inhibition, as well as studies like PURE-1, which is looking at checkpoint inhibitors alone in the neoadjuvant setting. And there are a slew of studies right now and looking at various different types of checkpoint inhibitors and different combinations, both in neoadjuvant and adjuvant settings. So I think it's a little too early to talk about safety profiles of combining. That's one of the biggest concerns, is can you give two therapies that have their own toxicities together, and will patients tolerate them? Certainly in the metastatic setting, a lot of the patients have already failed a platinum-based chemotherapy. And so people are looking at combination immune therapies or targeted therapies. But in the neoadjuvant setting, where the standard of care is to give cisplatin-based chemotherapy, it certainly would be interesting to see if adding a checkpoint inhibitor will improve complete response. And best case scenario, maybe we don't ever even need to take out your bladder if you have a complete and durable response.